We need some newer stuff.
We do.
So what is new? What's coming? What's coming in the
So
pipeline?
there's a FC neonatal receptor monoclonal, humanized monoclonal antibody that's being presented right now as a single-arm study that looks promising. There's a new oral BTK inhibitor.
Bruton tyrosine kinase.
Bruton tyrosine kinase inhibitor. It's PRN 1008. We happen to be on that clinical trial as well. We've accrued now, it's another multinational trial, single-arm open-label study. I think 7 patients have been put on it so far, but it's interesting in a mouse model how effective it was. So what we know about BTK inhibition through ibrutinib and whatnot is that it's not only critical for the B-cell receptor, but it's also involved in FC receptor pathway activation, much like SYK is.
Yeah, so it functions similar to a SYK inhibitor
Exactly, and also B-cell activation. So it has the potential to block both inhibition and block autoantibody production. And the nice thing about this particular drug is it does not inhibit collagen platelet aggregation, collagen-activated platelet aggregation. Now, having said that, there's absolutely no evidence that bleeding correlates with platelet aggregation studies. So, although I think we all thought that the antiplatelet effect that ibrutinib caused we knew and could correlate, it turns out that is not the case. But it doesn't inhibit that, and so perhaps the incidence of bleeding will be lower.
Hopefully.
Yes.
Yeah. So you have patients on this study
Yes.
now. Have you seen any bleeding?
No.
Yeah. Very interesting.
Yes.
And so is there anything at ASH on PRN 1008, or I guess not?
Just investigator meetings.
Anything that you know about that's new that we should be aware of?
The other one to mention, as I think Dr. Boucher alluded to earlier, was avatrombopag. So that one.
And there's lusutrombopag as well, which is approved for patients with thrombocytopenia and liver disease needing surgery, but not obviously for ITP.
Yeah, purely in a pre-procedural, preoperative setting. But avatrombopag may be something quite interesting, if it gets FDA approved, which we may suspect, but we don't have it officially yet as an FDA approved medication. But I believe it can be taken with food or without food is one factor with it. The response rates that I saw just in the abstracts that have been presented is roughly, again, in people who are heavily pretreated, like just like we talked about, fostamatinib was studied in a heavily pretreated population, so was avatrombopag. Not surprisingly nowadays, people who are enrolling on these studies after many years on various treatments. But the response rate was over 30% for having some kind of sustained benefit on, they had a specific definition for, I think, 6 out of 8 weeks towards the end of their treatment course, had to have a platelet count of 50,000 or more. So 50,000 is kind of like this a general kind of standard that's been applied, even though, like we said earlier, in real practice we may not be aiming for a number per se, but that is that's the mark above which they're aiming for response. So and the side effect profile may be a little bit different. It seems like the liver risk may be less based on what we know so far. The headaches remain prominent with avatrombopag, what I saw in the abstracts that have been presented. Arthralgia is also a feature of the medication from the clinical trials, so interestingly enough.
I think it may give avatrombopag a run for the money.
Really?
Well, the food effect is major.
Yeah.
Right? I think that's probably the biggest thing that we struggle with avatrombopag patients. You already talked about it.
Yeah.
That and the LFTs,
Yeah.
Right. Yep. And I will mention that I've seen a data set on low-dose decitabine with some encouraging activity. I think the mechanism is that it actually induces megakaryocyte maturation. And then there's also experience in Japanese literature of a new kind of recombinant thrombopoietin that doesn't react with endogenous thrombopoietin and cause aplastic anemia. So we have a few things to look forward to. I want to thank you both so much for participating in this. I've really enjoyed our discussion. And before we conclude, I'd like to ask you both to give some closing remarks. So Dr. Boucher, why don't you start?
Well, I think it's an exciting time for patients who have ITP now that we have many more options. It appears, though, that we now, with some of these newer agents, can prolong their responses and we may be able to reduce the potential side effects of the heinous corticosteroids that patients have been treated as the cornerstone and standard of care with.
Yep, very well said. And Dr. Mehta.
Yeah, thank you, Ivy. My pleasure to come as well. And my main take from the landscape of ITP now is that luckily we have so many new and robust treatment options available that have good response rates that we're shying away from the older type of treatments that had very minimal responses. So the landscape has definitely changed where we have different mechanisms to utilize treatments that are FDA approved with robust responses and durable responses. So definitely an exciting time for the clinicians treating ITP as well as the patients who are dealing with ITP.
Yeah.
And hopefully we'll build on this understanding about some of the ways to predict response and select the treatment for the mechanism active in this particular patient. So definitely quite exciting.
Yep, I agree. And I would like to conclude that I think that for ITP patients that are diagnosed, it can be very scary. This is a relatively rare disease. And I do want to mention that I have to remind myself to encourage patients to go to the PDSA support group and register and take advantage of those resources or other online support groups, because I think in addition to all of our hard work trying to manage their disease, that can be very, very helpful. And it's something that physicians should take advantage of. So thank you both so much. This has been a lot of fun. On behalf of our panel, we thank you for joining us, and we hope you found this OnC Live peer exchange discussion to be insightful and informative.